GERD is a multifactorial heterogeneous disease, and one size is never going to fit all. There are a myriad of different symptoms. There's a myriad of different mechanisms that drive reflux. And I think the important thing here is to tailor therapy. I think it is important for us to make sure that patients know that they shouldn't not take this serious if they're having symptoms that are occurring 2 or 3 times per week. I think this is an important thing. And if you're at the dinner table, and you see your spouse, your partner, visibly having heartburn or complaining about this, and this has become a repetitive thing, you should tell them you need to see your gastroenterologist. We have a lot of things in our toolbox, that can range from, healthy living to interventions that may require us to go in there and fix your anatomy. Reflux for the most part can be just something that happens where they need to take some antacids every now and then. Now, I will tell you that it's not a great medicine for everybody though. So if you're taking it and it's not helping you, you shouldn't be taking it. Being on a medicine is always a negative outcome. You don't want to be on a medicine because it's something you have to take every day, it's expensive, and it does change your body. It's there to change one thing, and that's going to lead to other things. So in my experience, what I tell patients is that first off, I need to make sure that you have the appropriate indication and that you're on the PPI. Because if you're not getting a benefit and you shouldn't be on a PPI, then it's only risk, no matter what the risk is, even if it's small. I think that when you look at the trials like the RESPECT trial, the CALIBRE trial, and even Stu Speckler's recent New England Journal paper, you can clearly see that there are patients who have anatomical issues that require more than just acid suppression. They really require an anatomical fix. And I think that's really where getting to a gastroenterologist, getting an endoscopy to see if you're actually having, injury, are you developing a stricture, erosions, and then potentially Barrett's esophagus. And if you do have Barrett's esophagus, that's an important thing because that can lead to cancer. Now, you've already done the most important thing as a patient. Once you've entertained the idea of seeing the gastroenterologist and they do that index endoscopy and they find out if you have Barrett's, because then we can control it, we can watch you, and there are even now new ablation techniques that we can actually do to treat Barrett's esophagus. But the key there is we have to be really aggressive with your anti-reflux therapy. In fact, if you still have refractory reflux and you're still refluxing, even if your symptoms are better and you're not responding to the ablation therapy, you may need an improvement in your anti-reflux barrier, and that's where these procedures come into play. When you look back at the traditional Nissen fundoplication, it was an excellent operation to reduce reflux. In fact, it almost eliminated reflux. And when you see pH studies after a well-done Nissen fundoplication, they have no acid exposure. But that was probably because it was too much, to be quite honest. And I think that's why we see a lot of these complications of dysphagia and gas bloat with that particular operation. And I think you can get away with a less aggressive type of wrap or fundoplication. And that's, once again, where I think the TIF procedure, allows us to kind of not go all the way and kind of do something that's a little bit less, but as effective in terms of, creating that anti-reflux barrier without all of these complications. And I think that's really the nuance of having something like a TIF procedure in our, toolbox when we're treating reflux. So in the RESPECT trial, we could see that, patients did quite well. And although, when we look at the overall data, PPIs worked in some people, it was definitely a big difference when it came to regurgitation with TIF. And I think that when you look at numbers needed to treat that are less than 10, that's a significant number needed to treat to improve these patients. I really like it in the patients who have pulmonary issues and regurgitation and aspiration. So the esophagogastric junction is pretty complex. I think people don't remember that it's not just one sphincter, it's actually 2 sphincters, and then there's a lot of anatomical considerations. So there is the intrinsic LES, the lower esophageal sphincter, and then there is the crural diaphragm, which provides that extrinsic pressure signal. And then there's the anatomy, the angle of His and the gastroesophageal flap valve. And I think when you look at all of those combined, you have to consider those when you're thinking about therapies. So when you see someone with a type 1 or 2 flap valve, and they have an incompetent EGJ, and they have refractory acid exposure, even on PPIs, those are people who require some type of buttressing or improvement in the anti-reflux barrier, and I think that's really where the TIF procedure comes into play. If someone has a defective crura, which you may see with a type 3 flap valve or a type 4 flap valve, fixing the sphincter is not going to be enough, because really they'll have a hernia, and every time that sphincter opens up, they're just going to continue to reflux, and you really have to treat both. I think one of the novel approaches that we're seeing is this kind of combined hybrid approach where people are fixing the diaphragm and actually then performing a TIF procedure. And I think that has biologic plausibility. When you think about it, you're fixing the crura, which is really important, and then at the same time you're providing this kind of partial fundoplication-like anatomy, which is good because we don't want a full fundoplication because then those people tend to have more dysphagia. So it gives you kind of like a little bit of leeway. So I think, one of the surprising things is that how durable it's been shown in some of these trials like TEMPO. And I think, the TIF procedure, it's one of these things that, I like because it's not a big intervention for these patients, and it's something that, you don't burn bridges. And we know GERD is a progressive disease. As we get older, the EGJ gets weaker, the crural diaphragm gets weaker, we gain weight, and we're continuing to swallow. So these are things that are going to disrupt the anti-reflux barrier. And it's nice to know that if I need another procedure later on, I'm not going to burn that bridge, because I know, or I hope that at least my patients are going to live 40, 50 years, and we have to be prepared for that. We have to think more like we're playing chess, like what's going to happen in the future. And by not burning bridges, that's extremely important because you don't get many shots in the esophagus. And if you can get one more, that's a big deal for me. I think it's really important to stress the fact that when you get a TIF, it's important to control the lifestyle, and you can't ignore that. And if you only treat the anatomical thing and you fix the anatomy with these particular procedures, you still have to control your diet, you still have to lead a healthy lifestyle, because you in essence can disrupt that wrap if you gain a lot of weight, you do a lot of exercises with high intra-abdominal pressure, and you're doing things that may be at risk for disrupting this. You really have to be cognizant of the fact that this is a change for you, and you still need to live a good healthy lifestyle, focus on diet and really reducing your weight and watching that, because that'll give you the best outcome with your TIF procedure.